The topic I have today is hypoglycemia for patients with diabetes management. Hypoglycemia is defined as low blood glucose levels in diabetes when the blood glucose levels are below 4 millimole per liter. Plasma glucose levels are unrelated to the severity of hypoglycemia experiences. Hence, it's hard to categorize hypoglycemia experiences on the basis of the level of glucose in the units of millimole per liters. Thus, literature supports the division of hypoglycemia according to the basis of the severity of experiences that patients experience in 3 categories as mild, moderate, and severe. Mild hypoglycemia is defined an event when patient, him or herself, can manage the hypoglycemia event and can self-treat. Moderate hypoglycemia is defined as the event when patient can self-treat, but it is a big disruption in their day-to-day life. Severe hypoglycemia is defined as when patient is unable to self-treat and needs help from another person or may have experienced unconsciousness or a fit. Physiology of hypoglycemia includes when the blood glucose levels goes below 4, then alpha cells comes into action. Beta cells do not release any more insulin, whereas contra-regulatory hormones come into action, which enhances glucose production by hepatic gluconeogenesis. It's very important to identify what are the risk factors and the causes of hypoglycemia in each individual, because each individual is individual, so we need to identify their individualized causes of hypoglycemia. The causes of hypoglycemia can be multifactorial. It can be related to increased insulin secretion by partial beta cell recovery or in honeymoon period among type 1 diabetes mellitus. It can be due to accelerated absorption of insulin or related to more exercise than their usual routine. It may be associated with renal failure or reduced renal clearance. It can also be related to excessive dose, the dose that is administered that is higher than what they need. Higher dose can be associated with multifactorial factors again. It can be patient-related, where patient may have administered the wrong or higher dose. It can be prescribing-related. It can be dispensing-related. So it's important to identify what was the dose given of insulin or medications that were administered, which contributed an adverse side effect as hypoglycemia. It can be poor match of therapy to lifestyle, like shift work or unroutine exercise again. It can also be associated with increased insulin sensitivity because of counter-regulatory hormone deficiency or post-pregnancy and menstrual cycle variation. It can also be associated with weight loss when someone has reduced the weight, but the therapy has not been reduced accordingly. It can also be related to inadequate carbohydrates when patient has anorexia or is unwell or having vomitings, when patient has missed meal or delayed meal or have decided to go on some special diets. So breastfeeding and excessive exercise with limited carbohydrates can be another cause. Other factors to explore can be alcohol, because when people are binge drinking, they may just drink, do not eat, which may suppress their hepatic glucose release and counter-regulatory response from the body. It can be associated with drugs that can increase the action of insulin, like sulfonylurea and non-selective beta blockers. Sign and symptoms can be autonomic or neuroglycopenic, which includes trembling, sweating, pounding, heart, fast pulse, change in body temperature, tingling, heavy breathing, pale anxiety, and hunger. Whereas neuroglycopenic symptoms can be slow thinking, blurred vision, slurred speech, loss of coordination, numbness, trouble of concentrating, dizziness, fatigue, and coma. These are the most common symptoms that most of the patients have expressed when they experience hypoglycemia, which includes blurred vision, lightheadedness, dizzy, trembling hands, thumping heart, weak and trembling knees, feeling hunger and looking pale, and have sweaty skin. Hypoglycemia management for the conscious patient is different than unconscious patient. So patient advice, it's best to keep it simple. However, I have kept a little slide here for health professionals to understand how to manage or fine-tune the management of diabetes. For patient advice, keep it as simple as you can. If they experience any symptoms of hypoglycemia, advise them to test their blood glucose levels. And the treatment can be 7 to 8 jelly beans or 3 large glucose tablets or 1 tablespoon of sugar, jam or honey in little glass of water, or a half glass of fruit juice. So when we say fruit juice, be cautious and please advise them, ensure that it's not sugar-free or it's not diet drinks, because that will not be a treatment, that will just be a kind of reassurance, but it won't act as a treatment. So treatment is important, but simultaneously rechecking is most important to see whether treatment was effective or whether it has given any results. So wait for 5 to 10 minutes and then check sugar levels again and if they are more than 4, then they can have a snack, but if they are still below 4, they need to have the treatment again. For health professionals, I kept this slide most importantly because sometimes we come across some cases where patients are having hypo and then they are having hyperglycemia contributed by the treatment of hypoglycemia. Therefore, for our understanding, it's important to know if the patient is conscious and blood glucose levels are from 3 to 4 millimole per liter, then they need about 15 to 20 grams of carbohydrate to treat hypoglycemia. But if patient is conscious and glucose levels are below 3, then they need 30 grams of carbohydrates. And the recheck remains the same to check the sugar levels after 5 to 10 minutes. So this is for conscious patient. For unconscious patient, if it happens at home, then if a family member has found the patient unresponsive, then the most important is to check the sugar levels to find out if the reason of being unresponsive is hypoglycemia. Give IM glucagon and call for help. For health professionals, if it happens in your acute setting or in the hospital, then this is the guideline that we follow. Give the recovery position, call for help, glucagon, IM injection, and if patient has IV excess, 100 mL of 10% glucose can be given as SLAT. Test blood glucose again in 10 to 15 minutes and repeat the therapy if blood glucose have still not up above 4. Nocturnal hypoglycemia is another problem that our patients feel. Symptoms can include sweating, restless night, and wakes with headache. Management can be, we can advise patient while stabilizing the therapy to check sugar levels before bed and between 2 to 3 a.m. Report the results to you guys, and if blood glucose levels before bed are below 7, they can have a pre-bed snack. And it's important to titrate the insulin or their therapy according to their blood glucose levels. If they experience any hypoglycemia, it's important to titrate their therapy there. Hypo-unawareness is another fact. About 25% of patients with type 1 DM experiences hypo-unawareness, and their risk to have severe hypoglycemia increases by 6 to 7 folds higher than those who don't have hypo-unawareness. Aging is also another factor which reduces counter-regulatory responses, which may increase the risk of severity of hypoglycemia. Prevention, education at each event when you meet with your patients, and ensure to give them a glucometer and appropriate strips so that they can test their glucose levels. These are some of the discussion points which were kindly raised by organizing committee, which were discussed in SLAT meeting in County's Medical Health. I have tried to incorporate these questions in this session. These are the references, and I don't think we have time for question and answers. However, we have got 3 take-home messages: that a prescription of IM glucagon and its explanation of its usage is crucial, review medications and its relevant risk to contribute hypoglycemia and its management at each consult with your patients, and review medications from post-hospital admission for titration, because when people come to hospital, they usually need lesser insulin and lesser medications because of the limited carbs in the hospital food. That's all about my talk. Thank you so much for listening.